Hello, everybody, and welcome to day 2 of the first, hopefully annual ENIGMA and ENIGMA IPV and Pink Concussions IPV Brain Injury Conference in the Science and on the Ground. We are so excited to have you back for day 2. Day 1, from what we hear, was a fantastic success, and we're looking to and hoping to build on that for day 2. So we are very excited. We are very excited to see such a broad geographical representation of individuals who have registered for this conference. We are sitting currently at 485 registrants, and that makes us so excited. And we have many people from across different spectrums of stakeholders, anyone from trainees and students to medical service providers, research faculty and staff, as well as our advocates joining us, which we're so excited for. When we first set out to do this, we were hoping to provide a free, virtual, and accessible conference that could be seen by all, especially those of you working with IPV brain injury who haven't had a chance necessarily to join these conferences in the past. We wanted to get you, if you are first joining this for the first time, to fill out our pre-conference survey. This helps us with building on for next year, as well as understanding what your needs are and where you're coming from before we get started. I'd also like to take a moment to say a huge thank you and shout out to our conference organizing committee. And particularly, I want to point out to Katie Dorman, who was behind the scenes doing all the administration for this, and many of you probably got lots of emails from her with conference links or getting bios. So thank you, Katie. I also want to give a big shout out to Sophia Thomopoulos, who is the overall ENIGMA coordinator. She has been instrumental in getting this webinar going and providing all the technical support needed for this. So thank you. We also would like to share on behalf of our conference committee, our statement on diversity, equity, and inclusion. You can take a quick read of this. We also will be including it online to make sure you are all aware of where we stand. We'd also like to acknowledge that our work spans many First Nations, Inuit, and other Indigenous territories. Moving forward in a way that promotes anti-racism and inclusivity, we are committed to educating ourselves and understanding the truth of our shared history with Indigenous peoples. I will ask you as we move forward with this conference, if you have questions for any of our speakers, panelists during the day, we ask that you add them to the Q&A, so then our panelists and our speakers can answer those questions at the end of their talks, or they can answer them online after they have finished speaking. So with that, I would like to welcome our first panel our panel for day 2, which is moving IPV brain injury work forward. And it is my honor, if I can get everybody to turn on your cameras from the panel, but it is my honor to introduce our panelists. We have Dr. Julianna Nemeth, who's an assistant professor of public health at The Ohio State University and is a health equity intervention scientist and has worked with the Ohio Domestic Violence Network. We have Dr. Paul Van Donkelaar, who is the co-founder and scientific advisor for supporting survivors of abuse and brain injury through research, the SOAR program. He is also a professor of the School of Health and Exercise Sciences and associate vice principal research at the University of British Columbia's Okanagan campus. We also have Karen Mason, who is the co-founder and executive director for the SOAR program, as well as Katherine Snedaker, who is a licensed clinical social worker and is the pro bono executive director and founder of Pink Concussions. We also have, I think, Dr. Katherine Iverson, I believe she will be joining us, who is a clinician investigator at the Women's Health Sciences Division of the National Center for PTSD at the VA Boston Healthcare System, an associate professor of psychiatry at Boston University School of Medicine. And finally, we have Dr. Willie Stewart, who is a consultant neuropathologist at the Queen Elizabeth University Hospital in Glasgow and holds an honorary associate professor status at the University of Glasgow and the University of Pennsylvania. And my name is Dr. Carrie Esopenko, and I'm an associate professor at the Icahn School of Medicine at Mount Sinai in New York City, and I will be moderating this session today. So with that, I would like to welcome our panelists, and we will get started with some fantastic questions. Welcome, everyone. I'm seeing that my lighting is doing great tricks. It's almost like I'm in an MRI. So what I wanted to start with was, yesterday we talked about the gaps in moving IPV brain injury, or what's currently happening in IPV brain injury research. So today, after yesterday's talks, we wanted to start with how we can move this work forward. So what we'd like to do is ask each of you if you can give us your view on one priority or action area item to move either from a research or care perspective, the field forward. Julianna, let's start with you.
Sure. Thanks so much for having me here. Well, so our work in Ohio, as you probably have gathered from yesterday, is very much grounded in participatory action research. And we, in 2022, gathered information from the community about priorities for research, but really priorities from research that are coming from the community. And one of the, I think, biggest gaps is understanding. We recognize that this is a problem, but what do we do next? How do we connect survivors living with brain injury to the care that they need? And not just any care, trauma-informed care that really meets survivors where they are given the current situation that they're in, and where they are in the life course in relationship to that injury. So, some survivors are, walking into shelters with immediate injury and immediate, safety concerns. Some survivors are, walking into substance use treatment clinics maybe years later, and, need to be recognized that they've been living with a brain injury for a long period of time, and maybe their course of treatment and trajectory is much different. But really, it's kind of like I'm, as a clinician sitting here with someone in front of me, and I really need help to navigate the system in front of me in a way that's trauma-informed. And I need to be able to connect this person in front of me in a way that I recognize and I honor their experience, and I know that the next person that I'm connecting them to is also going to honor that experience. So, and I think we need to do that in a way where we feel connected in the process of doing that. So I actually think it's that, like, how do we connect people through systems of trauma-informed brain injury aware care that really honor people's needs where they are through the life course and through their current need in the process, recognizing both care providers' awareness and needs as well as survivors' needs.
Great answer. There's a lot there to work on for us to move forward. I think from that, switching over to a stakeholder perspective, Karen or Katherine, you guys can rock, paper, scissors on who wants to go next, but maybe Karen?
Sure. Certainly, everything Julianna said. At the same time, all of us, all 400 plus folks who are on this call, we get it. And yet there are still so many out on the front lines who don't. So I come from a very similar perspective to Lynn Haag yesterday when I say education and awareness are really critical. And when I say education, I'm talking curriculum for doctors, nurses, social workers, go beyond that, paramedics. We already talked about training for paramedics yesterday, and also everyone else on those front lines, because the awareness still isn't there enough to be brain injury informed as well as trauma informed.
Katherine, did you want to follow up on that?
Yeah, so what my role is I feel like as a social worker, I've got a step into the formerly Twitter X world, social work from the point of building communities and accessing different communities. And I know a whole bunch of really cool researchers and get to dabble in research with very smart friends. So for me, it's putting this topic where it's not expected, we had a contact at Forbes in 2019, and we got an article in Forbes, and it's reaching out to reporters and it's putting it, I always wish that we could do domestic violence and have, the title of the talk being top 10 tips for golf. And then it turns out to be a domestic TBI conference. So I feel like my role is just to get the topic out in unexpected places, because I do feel like there's a giant aha. I think once someone reads an article on this, it doesn't disappear in their mind, which is, I think it's one of the really positive things about this, whether it's somebody that's worked in TBI, with someone that's worked in TBI for a number of years and never thought about domestic violence, or somebody who worked in domestic violence and not thought about TBI. But sort of once the light bulb goes on, it's on.
Yes, there's a lot there too. We're going to be unpacking a lot of these responses, I think. Willie, how about you?
So yeah, I mean, I echo everything that's been said, and one of the frustrations I have is that we know the prevalence of intimate partner violence issues. We know the frequency with which traumatic brain injury contributes to that. And yet when you go out to the research communities and you look at the care providers, they don't seem to know that. So, there are existing data sets and existing collections where this problem must be in there. It must be getting recorded in some way, but it's not. So we started a project a few years ago looking at an existing dementia longitudinal cohort where 700 midlife individuals had been recruited for studies in brain health. And I said, well, you must have intimate partner violence in there. And they said, well, I don't know if we do. And when we went in and looked, we found there were 150 or so individuals with reported stories, of which about 100 had histories of traumatic brain injury. And suddenly you can start to answer questions if you look at cohorts of data like that. But these have existed for a long time. And awareness is the issue amongst researchers, but also amongst the wider public. And it's challenging. Last week in the House of Lords, a great success, we had a question asked about intimate partner violence and traumatic brain injury and intimate partner violence. And it was interesting. I'll maybe share the Hansard, which is our Parliament's minutes, if you like, of the communications. And the follow-up conversation started to wander into sport and talk about sports concussion and rugby and football. But that wasn't what the question was about. So why are we talking about rugby and football? And just as a parallel, I had fortunate position to have two papers published within a week of each other in the same journal, one on rugby, one a very, very important paper on intimate partner violence. The one on rugby got international attention, was picked up in newspapers and picked up in media everywhere. The intimate partner violence paper went out with a murmur, despite the fact it was promoted and everybody knew about it. So it's a hard conversation to have with people, and some people don't want to listen to it, but I think we need to keep telling people about it.
Could not agree more. Could not agree more. And Paul, definitely not last but not least, what would your action item be?
First of all, I should mention that Karen and I are at our cabin in the wilderness in British Columbia, and we're reliant on Elon Musk's Starlink to keep us connected. So if we freeze, just move on to the next question and speaker. But yeah, I think from our perspective, more funding for research to actually get the work done. I mean, it's coming slowly but surely. And I know Eve, who we'll hear from later, has been at this for a long time and went for many years without funding because granting agencies weren't getting the message. So again, advocacy at all levels, not just front line support staff who are doing the work, but all the way up to, provincial, state, national, and federal organizations that provide funding so that they are informed and can help us do the work.
Yes, if anybody hears from our funding agencies, we need you. I think this dovetails really nicely into the big question we all have is we've been seeing, we all know in the research side who've been working this, of the prevalence of IPV-BI or what we expect the prevalence to be. We're starting to see that, there are long-term effects. With Dr. Dom's O'Connor's talk yesterday, we heard a lot of that. How do we keep this momentum going? How do we push through the funding agencies? How do we get those curriculums out there? How do we keep this momentum and move it forward? Yep, go ahead, Katherine.
I just wanted to say that I think this is a really tricky one. And I walked out of a Boston Globe in-person article where they wanted me to estimate how many women with IPV-TBI will have CTE. And that's not the direction we want to go. And we do not. And I thought that yesterday's talks really sped to that. So, I wanted to start out with what we don't want is, everybody with domestic violence is going to end up with CTE, and that's going to have the clickbait, right? And that, oh, well, maybe it's good we go that direction because we'll get a lot of publicity. So that's not what we want. And then I'll let my lovely fellow panelists talk about what we do want.
It's interesting that you say this because we just had Willie saying they can't get clicks. So it's an interesting.
You can get clicks if
middle ground.
If they tie IPV to CTE, right?
Yeah,
they want that connection. They don't want IPV brain injury, that piece, right? And Willie and I were really careful with our 2019 campaign for women to pledge their brains in the UK to not be led in that direction. Research is important, but not damaging for people.
Sorry, and I think that I'd say, I think. So the work that Kristen and the Rebecca were leading on was incredibly important. It was a really detailed and thorough examination. It went in without biases. It did a rigorous evaluation, and then it backed up with an extensive case series, which again were unbiased in their collection. And what it demonstrated is CTE is not that much of a problem in this, despite biases that people may have. Unfortunately, that important message gets lost because it's not clicky. I think if there'd been one or two cases that we could have said maybe that's CTE, the headline could have been intimate partner violence with brain injury leads to sportswomen's brain injury, CTE, and that would have got sudden attention. I think the more nuanced approach, the more important message that actually we're dealing with something which is really complex here is just lost for some reason in the conversations. I think though what is important that I've seen in UK, but I'm seeing now funding agencies in the US, is that they are talking more about groups of individuals with brain injury who are frequently missed in research. And it used to be children and the elderly, and sometimes it was in fact athletes were included in there for a while as well, which is bizarre in itself as a contradiction. But I'm seeing the list now includes intimate partner violence, often the first thing mentioned. And we saw that we've got a research platform which was launched a couple of weeks ago, TBI Reporter. So if you TBI-Reporter, you'll find it on the internet. And one of the funding agencies involved in that were very specific that they really wanted this to drive forward research in communities, including intimate partner violence, and that's been one of our focus points. But it came up in the House of Lords discussion last week. So I think we're beginning to get through to people that can hold the purse strings and make us researchers go in certain directions.
And Karen and Paul, you guys have had some success with this in Canada. Do you want to talk about that?
Yeah, I was thinking about that, as we were speaking, and I was referencing back to Catherine's point about reaching out to journalists and getting the message out there. We've been screaming, I've certainly been screaming as a raging menopausal woman about this topic for 7 years now. That's still as long as Paul and I have been doing this work. And we have seen incredible growth in attention, and it feels like we're not pushing a boulder uphill anymore. And it did in the beginning. And we have recently, along with Angela Colantonio and Mike Ellis, put in a collaborative grant proposal for a grant that was by invitation, for which they are only selecting one person to receive or one group to receive. And the grant is brain injury, intimate partner violence. And it's the Public Health Agency of Canada. So that is huge, a grant specifically on this topic by invitation to researchers who are known in Canada to be doing the work. So that's hopeful.
We all have our fingers crossed for you on that one. Julianna, what about yourself? Or Paul, sorry, did you have I saw unmuting happening, but.
Oh, no, just HAG is also part of that group.
Yes.
And if and when we get the funding, Lynn and Karen will be doing a lot of work around promoting and increasing knowledge and all that. So it's definitely, we're very excited about the opportunity.
Doing wonderful things in Canada. Well, and been off course, and I'm like, what is the original question that you asked? But I actually think one of the most important things is to tie the work to survivors' stories, and putting survivors' stories at the center of what it is that we're doing, and putting community organizations that are working with survivors at the center of what it is that we're doing. I think one of the things that we're doing here in Ohio, last year, these community conversations that we had were really Ohio State. The research that was started here in Ohio State actually came out of, it was actually a community-based grant from the Ohio Domestic Violence Network, where we did a little bit of research that turned into something. And we had amazing researchers at Ohio State that do brain injury research, and we wanted to move forward research in this area at Ohio State, but we didn't. I was concerned that we didn't do this in a way that wasn't informed by the community. So we had these conversations to say, how are we going to do this in a way that's informed by the community? But what ended up happening is the community said, hey, we really want to do a lot of work together. And so we're actually moving forward something called the Brain Injury from Violence Care Alliance. And that group is really comprised, it's like a multidisciplinary collaborative with our statewide funders and our, so our government agencies are at the table, and our community providers and survivors and researchers and clinicians kind of working together. And we're using an advocacy framework to really guide the work that we're doing that focuses on public, provider, and our policymaker awareness as a base of what it is that we're doing, and then kind of moving up to changes in policy, eventually, hopefully, that will move the needle on this. So being very strategic about the work that we're doing to change institutional practices that really will eventually change things on this. Research is a tiny piece of that. The research that we do is a tiny piece of that. The research that we do hopefully supports that, but the reality is a majority of that work is, to begin with, is actually public awareness, provider awareness, and awareness of our governmental people that are actually making policies and deciding how to fund things. So the work to actually change systems in the long run requires us coming together and strategically working together to change things. And research, despite the fact that we'd love to say it's everything, it really has to come in and provide the supportive role to what it is that the community needs. And we really need to follow these guidelines for how social justice change comes about. And that's actually like public health framing, that we need to follow. So I would suggest we kind of use the best models for how it is that other social change comes about, and that we bring multidisciplinary collaboratives together, and we follow the empowerment of communities in the work that we do around this issue. So.
Thank you. And I think that actually dovetails nicely into one of our other questions, which is how do we reduce those silos between research and care providers, stakeholders? How do we develop those collaborations? How do we get people working together? So like, for instance, if you had a how-to for a researcher who wanted to help work with the community, how do you do that? How do we make sure we're not just sitting in our office publishing papers, but actually reducing those silos? Whoever, it's open access here.
Well, one, the organization with ENIGMA and IPV that you've started with the fireside chats and the library and the resources, Pink Concussions, we have a monthly training. I think that there are, I'm sure, Karen and Paul have resources too. I think it's just, we're a really great bunch of people to get to know. Like, it's like, get to know us, write us an email, text us. A lot of the work that I've done in this space was out of an NIH meeting, you know. So I think I mean, everybody I know will take a phone call and take an email, and just reach out. And I think it's the of all the silos, this is one of the coolest ones to relate to people, and I really think we're building our own community. So I think that's super key in events like this. So thank you all for putting it together.
We found Tinder worked really well.
I was actually wondering if that was coming in. I was wondering if that was coming in today. So yeah, you're going to have to explain.
I mean, online dating isn't for everyone, but certainly that's what brought a scientific researcher, neuroscientist, and a community advocate together in our case in running a community organization. But I think the lessons learned can be applied in all kinds of contexts in terms of, you know, Paul as a researcher having to open up to having folks in community be more kind of prescriptive about the work that's being done and provide feedback and be actively involved from a directional point of view, like Julianna spoke of. I think for some researchers, they get very focused on that little piece of work they do that is so important, and the huge amount of knowledge they have about that small thing. I don't know, you can speak to that better than I can.
Well, I think an important perspective to take for researchers is to leave your credentials at the door and just learn from the experience of folks who've been there and done that, and have that inform your research questions, and work with community partners to help you design research studies that are going to answer questions that have a direct impact on the work that they do. And so, you know, yes, you know, you might be the smartest person in the room based on years of education or whatever, but just leave all that behind and be open to being told that what you think and how you're approaching things might not be the best way, and let go of, you know, as scientists, we like to control everything. I think quite often, especially with complex issue like this, I really let go of that desire to control and be open to being flexible in your thinking.
So over the years of research, and certainly the last few years, I've done a lot of things to communicate with our research to communities. I think Tinder might be just a wee bit of a step too far. I mean, I'll raise it at home when I get home, but I think my wife may have something to say about that. But you know, it clearly worked. We in the program that I mentioned, TBI Reporter, one of the things that we built in right from the outset is what we call PPIE, or patient and participant involvement and engagement, participative research. And actually, we in our executive, so the management group for this program, which is a huge multi-center program to really, you know, accelerate research in the UK in traumatic brain injury. The executive committee, two of the members of the executive are lay representatives who are leading the PPIE committee, who in turn will review every single project that comes forward to us. So we're trying to build in from the outset that everything we do has review by the communities that we're actually working for, not just as researchers thinking, here's a super idea, let's do it. So we're actually listening to what the community we're working for are looking on it as priorities. And as well as listening to that feedback, we're also trying to set up engagement events so that we can take our research out to the groups that, again, we're working on behalf of. And I think, managed to persuade the rest of the executive, my group, that possibly the highest priority group we should work with is Intimate Partner Violence group, because we've done the athlete conversations, we've had our conversations about other forms of traumatic brain injury. There hasn't really been a good awareness raising and engagement exercise with intimate partner violence in this way. And I think they've kind of agreed. The House of Lords discussion last week probably helped, because, you know, if government are thinking about it, then it's probably a good idea that the research group get behind it too. So I'm hoping that sometime early part of next year, our first reporter community public engagement event will be engaging with intimate partner violence community and having that conversation about what their priorities might be.
And I just want to add one point to that when we're talking about engaging with our intimate partner violence communities, that we also make sure that we're thinking about intersecting identities and making sure that we are, you know, going out to our organizations in the LGBTQ+ communities. As we're seeing, there's a lot of IPV occurring in those communities, and likely a lot of head trauma and brain injury as well. So as we start moving forward with that, I hope that we can make sure to engage those intersecting communities as well. Julianna?
I think one of the things that we learned from our community conversations last year is, and why we're going with brain injury from violence here in Ohio, is that power-based violence is, I mean, what we're learning is all of the violences that target communities that have been historically marginalized and oppressed target the head and the airways.
Yeah.
So when we're talking about police brutality, for instance, when we're talking about sexual violence, for instance, the head and the airways are targeted at higher rates. And we definitely heard, we can't leave out human trafficking in this conversation. We can't leave out sexual assault in this conversation. We're not measuring it yet, but we actually have to bring a diverse group to this table to talk about this. So even though it's not there in the numbers yet, we have to address this in an intersectional framework. And so that's why here we've moved already to a different way of conceptualizing what it is that we're even doing. So I totally echo what you're saying, Carrie, and it's why we're even using a different language when we're talking about what it is that we're doing.
And I just want to throw in that within that context, ages too, where we have silver versus, you know, that within the context of all those communities are different ages and vulnerabilities of different ages. And that's been the senior community.
Yes, and thank you. And so the panel is coming to an end. I would like to thank you all, but before we end, I would like each of our panelists in 15 seconds or less, can you give us one positive thing to think about moving forward? So we've seen so much forward movement. We've, you know, Eve's going to talk to us next, but she's been pounding on this wall for years, and it was silence for a long time. But now there's not as much silence. So can each of you sign off with giving us one positive thing you're seeing as we move forward in this area?
I'll go. So we've got, I think people are now listening. So we've got governments listening, we've got funding agencies listening, you've got 400 odd people online listening on this event. And within research communities, when we sit in our executives and say, here's an idea for an engagement event, intimate partner violence, people are listening and we're making that happen. So that's a big change, even in the last few years. So that's a positive.
And I would say that people are reaching, organizations are reaching out for like, hey, can you come and speak? Where for those first 5 years, I was pounding on doors going, can you throw me in for the last 15 minutes of that talk? So I really believe that ears are open. And I do think if there's a silver lining to COVID, that's, COVID did open the universal experience of IPV across communities, across international lines. And talking across international lines, we have Scotland and Canada represented here. So key. Let's not reinvent the wheel.
We were invited to speak at Canadian Forces Base Esquimalt, which is a base for our military on Vancouver Island. It was a voluntary event, and about 40 people attended a full day training that Paul and I delivered. Among them, military chaplains, military police, social workers, an aviation mechanic, who afterwards gave feedback that it has nothing to do with his job, but he was so glad he'd chosen to come to this and he would use the knowledge he gained just in his life. So I think that's a huge positive. And there were probably 8 to 10 men out of this group of 40. That's huge.
Amazing. Julianna?
You all give me hope, but I also think that every survivor that says, oh my gosh, this is my experience and thank you for the work that you're doing.
Awesome. Well, with that, thank you to the panelists. We're very grateful to you joining us today and having such a great discussion.